Welcome to this final sprint explainer. We are taking strict clinical guidelines and transforming them into a rapid-fire case drill designed specifically to train your brain for test day pattern recognition. Look, if you're preparing for the wards or the boards, you already know that time is your absolutely most precious commodity. So we're taking the highest yield source material and distilling it right down into pure, actionable clinical logic.
Yeah, we're skipping the pleasantries in the agenda today because it is time to drill high-yield stems, hone in on key clues, and actively dodge those devastating exam traps. We're using large, readable case cards with a classic board-style format. No tiny multi-panel collages here, just one high-yield vignette at a time, so get ready to test your reflexes.
All right, Section 1, Thyroid Crises and Nodules. Let's dive right into our first system, the thyroid. This is an area where clinical presentation meets very strict lab parameters, and where biochemical thresholds must always dictate your next move. Consider your first patient. They develop a postoperative high fever, tachycardia, hypertension, and lid lack. But pay super close attention to the negative findings here. Absolutely no muscle rigidity and a totally normal creatine kinase. So what's the most likely diagnosis when that clock is ticking?
The best answer is thyroid storm. And your key clue right here is the complete lack of rigidity. That specific negative finding perfectly steers you away from the malignant hyperthermia trap. Malignant hyperthermia is going to present with very similar hypermetabolic signs, but you'll see an elevated CK, hyperkalemia, and severe muscle rigidity. Another trap on the differential is a pheochromocytoma crisis triggered by anesthesia, but that typically presents without the high fever.
Now, checking out the standard algorithm for thyroid nodules, notice how the TSH level and the ultrasound strictly gatekeep the imaging steps. The absolute rule of the game here is biochemical diagnosis before functional imaging. Let's actually put this into practice.
Applying that exact algorithm, if you've got a patient sitting in your clinic with a brand new 2-centimeter thyroid nodule, what must you do first? You really have to stop and think about the pathway before you even reach for a needle or a scanner.
Always prioritize the TSH level and ultrasound. Jumping straight to a fine needle aspiration biopsy or a radioactive iodine scan is a classic test day trap. You only proceed to radioactive iodine scintigraphy if that initial TSH comes back low, which indicates a potentially hyperfunctioning or hot nodule. Otherwise, you're evaluating for an FNA based strictly on the ultrasound features and the size of the nodule.
And remember, pregnancy completely shifts these baseline lab thresholds. Because estrogen increases thyroxine-binding globulin, total T4 levels naturally rise. But even more importantly, HCG actually acts on the thyroid directly.
So, keeping that exact physiology in mind, if you see a first trimester patient with a highly suppressed TSH, like less than 0.1, but her free T4 is perfectly normal, do you diagnose overt hyperthyroidism?
Nope. The answer is no. This is a completely normal physiologic change. HCG naturally stimulates the thyroid follicles, and that causes a feedback suppression of TSH. You absolutely must rely on the free T4 before diagnosing or treating. The really dangerous trap here is initiating antithyroid drugs like PTU or methimazole based on a low TSH alone, which could seriously harm the patient. You only consider treatment if the free T4 is actually elevated.
Section 2, Adrenal Cortex Case Drills. Let's see how this logic builds as we move down to the adrenal cortex, where the lab thresholds get even more specific, and honestly, the clinical stakes get much higher.
Listen to this presentation carefully. A patient with a known history of tuberculosis comes in with severe fatigue, postural hypotension, hyponatremia, hyperkalemia, and a very curious, highly specific lab finding of peripheral eosinophilia. So what's going on here?
This is primary adrenal insufficiency. Tuberculosis is a major global cause of this, but what's really fascinating here is the peripheral eosinophilia. It's a massive, highly specific clue that confirms a complete lack of cortisol. See, cortisol normally facilitates the migration of eosinophils right out of the bloodstream, so without it, they just pool in the blood. Also, note the hyperkalemia. That tells you aldosterone is missing, which completely proves this is a primary adrenal issue, not a secondary pituitary failure where aldosterone would totally remain intact.
And just like we saw with the thyroid, suspected hyperaldosteronism requires biochemical proof before you ever order a CT scan. If a patient has difficult-to-control hypertension and hypokalemia, you measure the plasma aldosterone and plasma renin activity first.
Burn this number into your memory right now. Greater than 20.
a plasma aldosterone to renin ratio greater than 20 points directly to primary hyperaldosteronism. A high ratio proves the adrenal gland is going completely rogue and suppressing renin. Only after establishing this biochemical reality do you ever move to adrenal suppression testing, and then finally, adrenal imaging.
Section 3. Neuromuscular Diagnostics. Let's shift gears away from strict endocrinology and into neuromuscular weakness, where a quick bedside test can entirely make or break your diagnosis before you even send off a single lab.
Okay, you have a patient presenting with fluctuating ocular weakness like ptosis and bulbar weakness like dysphagia that notoriously gets worse as the day progresses. What is your immediate, best initial bedside move?
The best answer is absolutely the ice pack test. Applying cold directly to the eyelid inhibits the breakdown of acetylcholine in the neuromuscular junction, which temporarily improves the ptosis. This completely bypasses the older edrophonium test, which is a classic test aid trap because it's notorious for false positives and, frankly, some really uncomfortable side effects for the patient, like severe bradycardia and bronchospasm. And remember, if the weakness was proximal and deep tendon reflexes were absent, you'd pivot your thinking entirely toward Lambert-Eaton syndrome instead. Finally, Section 4, Systemic Conditions, Heat Illness. For our final sprint in this explainer, we're tackling a high-stakes emergency differential that frequently catches people off guard.
Distinguishing between heat exhaustion and heat stroke isn't just about the temperature on the thermometer alone. It's actually almost entirely about the brain.
Picture a collapsing patient. They've been exerting themselves in the heat, their core temperature is blazing at 104 degrees Fahrenheit, and they are sweating profusely. What single clinical finding secures the diagnosis of heat exhaustion over life-threatening heat stroke? The absolute crucial point is a normal mental status. If their brain is functioning normally, no confusion, no delirium, no coma, it is heat exhaustion. This firmly rules out heat stroke and tells you to cool them down and push salt-containing oral fluids rather than immediately dunking them in an ice water immersion bath. And definitely beware the medication trap here. There is absolutely zero role for antipyretic therapy in either condition. You use physical rapid cooling, not Tylenol.
Well, we've covered a ton of ground today. You now know the key clues, you know the physiological traps, and you've memorized those vital ratios. But my final question to you is this. When the exam clock is ticking down, or when you are standing at the bedside of a rapidly deteriorating patient, are you going to trust the biochemical threshold and the physical exam, or will you panic and order the scan? Trust your knowledge, stick to the algorithms, and I will see you in the next explainer.